Understanding a few basic principles about the physics of ultrasound will help you operate your instrument better and also acquire better images. Now, the physics of ultrasound sounds like a very dry topic, like, do we really need to go here? Can't you just show me a few buttons and we're ready to go? But actually, that's true. This really is a talk a lot more about knobology than it is about physics. However, there are certain physical principles that we will be discussing throughout this podcast so that you have an idea about why we're getting these images and how to optimize their image quality on ultrasound machines. And the first button you may come across would be the B mode or 2D ultrasound button. And you simply press that button and that resets the ultrasound machine, gets it back to white dots on a black background. And that's called the brightness mode. The next button you may come across is the M mode. The M mode stands for motion mode, and it's basically a graphical representation of the returning ultrasound beams over time. So what that means is there's a little spike that's running through this tissue here. At the top of the spike is where the skin and soft tissue is. Here it runs through some muscle and some other muscle here, and then it runs into this little white line. This is the lung, and stuff that's not moving is very horizontal on M mode, whereas stuff that's moving is granular appearing on M mode. So it's a way to differentiate things that are moving from things that are not moving on the screen. That's one very rudimentary way to think about M mode. Now, Doppler is the shift of moving red blood cells as they come to and go away from the ultrasound beam. And we can see here, this is one type of Doppler called color flow Doppler. Red is flow towards the transducer, and blue is flow away from the transducer, as represented by this little scale over here. So that's one way to remember that. Red is flow towards the probe, blue is flow away. The other way is to think about BART, B-A-R-T, blue away, red towards. And essentially, this is a big aortic aneurysm seen here, and there's some yin and yang, or to and fro flow going on here. That's how that looks there. And remember that cosine of theta is in the numerator of the Doppler equation, and whenever the probe is at 90 degrees to the axis of the blood flow, you will not get a Doppler signal. That's because cosine of 90 degrees is 0, and that has a problem there with the equation. So you always want to be off 90 degrees. You want to be more parallel to the flow of blood when you're using Doppler, not as perpendicular. The same goes true when you're speeding in your car. When a police officer is at 90 degrees to the direction of your car, their radar doesn't work very well. They want to be more parallel, and that's why they can catch you all the way down the street. And here is a different type of Doppler called power flow Doppler. It's directionless. It's just orange only, and it's a more sort of sensitive type of Doppler. It's not concerned with trying to figure out which way things are going. It's just orange only. We see two pulsatile structures here. One happens to be an artery, one happens to be a vein. This is in the subclavian vasculature. When you get that close to the heart, with even venous structures, you'll see them pulsate as well. And so how would we differentiate an artery from a vein? Well, we could compress, or we could use pulse wave Doppler, where we take this gate and we steer it over one structure, and then we activate the pulse wave Doppler waveform, and we can see here it's having an arterial type of waveform. This is a velocity scale in centimeters per second, so the blood is going about 20 centimeters per second in the subclavian artery, whereas when we move that sampling gate over the other structure, we want to see what that is. It turns out to be a vein. This is subclavian vein. It's got more of a venous waveform to it, and a slower amount of flow, maybe 10 centimeters per second going on at this particular setting. So that's something to think about. You could use pulse wave Doppler to differentiate between arteries and veins if you wanted to. Now, what about the concept of ALARA? ALARA means as low as reasonably achievable, and it's a holdover from other types of imaging modalities in which radiation or gigantic magnet is used, and you want to expose the person to as least amount of radiation as possible. And some could be said about ultrasound. The minimal use of ultrasound exposure is certainly prudent. This is my son, Nicholas, here when he was in utero. I don't know, around 9 or 10 weeks or so here, oh no, probably less actually. We're using the endovag probe here. This looks like he's probably probably about 9 weeks or so, and we tried not to use ultrasound on him that much when he was a fetus. But if you look at the world's literature on this bioeffects of ultrasound, there certainly are a bioeffect of ultrasound. There's something called the mechanical index and the thermal index, where we know that there is energy going into the tissue, into the patient, and so we want to be aware of that and remember the Alara principle and not use unnecessary ultrasound when we don't need to. So that's something just to be aware of. Though the world's literature has not shown any epidemiological evidence of fetal abnormalities in humans from ultrasound exposure, and that's going back over 40 years now. So the next question I have for you is, how does ultrasound actually work? And let's ask our friend Sean Connery.
Re-verify our range to target. One ping only.
Captain, I just...
Give me a ping, Vasily. One ping only, please.
Aye, Captain.
So, no, Sean Connery did not invent ultrasound, but what happened there was, that was the movie The Hunt for Red October, and I know what you're already thinking. Why am I watching this podcast? Why can't I just watch the rest for Hunt for Red October? And I agree, that is a great movie. However, I think this one particular scene illustrates an important point of how ultrasound works. Basically, he said one ping only, and what that meant was he was trying to give away the Russian submarine. He was trying to defect, and so what he was doing is basically giving up his position and to the other submarine, the American submarine, which was quite near them at this time. And so the way it works is you release a ping, and the ping travels out to the other submarine and then back to the submarine who released the ping. And when it does that, that's called the pulse echo principle. And the way that works is, because you know how fast sound travels in water, all you do is listen for the time of flight it takes that ping to go out and come back, and therefore you can calculate distance. And ultrasound works exactly the same way. We know how fast sound travels in soft tissue, and the ultrasound machine releases the pulse. It goes into the body's tissue and then returns, and depending how long it took the sound to come back, it plots a dot on the screen in terms of depth. So the longer it takes the sound to come back, the further down the screen the ultrasound machine will plot that dot. And it turns out that the denser the structure, the brighter the dot, and the less dense the structure, the darker the dot. So bone is really dense, and so that's going to be really bright, really white. And the fluid-filled structures like the bladder or the gallbladder or free-flowing blood is not dense, and so that's going to be black on ultrasound. And so this is a way to talk about that that's the more professional way and the way we communicate with our colleagues. We don't say whiter or brighter or darker. Those are subjective terms that mean something different to lots of different people. So we say hyperechoic when something is more echogenic than the surrounding tissue. And we say hypoechoic when something's less echogenic than the surrounding tissue. And we say anechoic when something's jet black or completely devoid of echoes. So hyperechoic, hypoechoic, and anechoic. And something is actually isoechoic when it's the same exact echogenicity as surrounding tissue. We'll get to that some more later. Now, the probes have different frequencies about which they can toggle, and when you turn up the frequency, you can have better resolution. And so these two probes right here have superb resolution. However, the downside to high resolution is a decreased ability for the sound to penetrate. And so when we need to get the sound to penetrate to deeper structures in the body, we use lower frequency transducers. And so just to illustrate this concept, this is the endocavitary transducer, sometimes called the endovaginal transducer, though there are other places we can use it other than the vagina. But this is the transducer here. And when you put that high frequency transducer on a stick, and now you can get it closer to the organ of interest, like the uterus, well, you could take advantage of that close proximity now and turn up the frequency. And so you'll get much better resolution, which is why of 100 pelvic ultrasounds I do a month, probably 75–80% of the time or more, I'm using this endovaginal transducer. In fact, to try to find the ovaries using this lower frequency transducer or this one can be quite challenging, especially if the patient has any amount of abdominal wall fat, whereas this high frequency transducer is sort of like the BMI equalizer. I can always find the ovaries going through the endovaginal route, turning up the frequency, being much closer to that organ of interest. Now, another concept to be aware of is this concept of frequency. Now, frequency, I should say the way to adjust the frequency on the machine is by turning up the number from the general mode to the resolution mode, and then turning down the number to the penetration mode. Now, some ultrasound products show the actual frequency somewhere on the ultrasound screen. I'm discussing this type of product here who uses words instead of numbers. Now, I've seen some other manufacturers use words instead of numbers, whereas other manufacturers like using numbers. So either way, general is the middle frequency range. So if this particular transducer went from 3 to 5 megahertz, the general range would be at 4 megahertz, right in the middle. Now, as this image illustrates Morrison's pouch, this is all the liver here, this is the kidney here, okay, and this is the diaphragm over here. The interface between the kidney and the liver is called Morrison's pouch. Now, when I go from the general mode, I go ahead and push this button here. It's going to toggle it up to the resolution mode. I don't know if you could tell, but the dots got a little bit closer together. Things got a little bit more resolute. And similarly, if I hit this button again, and if I go down to the penetration mode, things got more pixelated and just a little bit more spread out. And so why would I do that? Well, if I had a really large patient with a BMI over 40 or so, yeah, I'm going to need to get the sound to punch deeper into the body, and therefore I would turn down the frequency to the penetration mode. But if I had a little kid, a 4-year-old who fell out of a tree, then I would turn up the frequency to the resolution mode, and because I don't need to get the sound to penetrate as far, and I would get much better resolution. For the most part, though, I leave it on the general mode, and I get done what I need to get done. The transducers have different footprints, too, and you may be wondering why that's the case. Well, here's an example of what we call the C60. C stands for curvilinear, 60, the number of millimeters across its surface, or 6 centimeters. It's a very large footprint. It's got these multiple elements lined up here in an array, and you can see as you get to the edges of this array, those scan lines spread out a little bit. When you're straight down the middle, they're a little closer together. You get out to the edge again, they splay out from one another. So whenever you're working with an array like this convex array here, the best resolution is going to be usually right down the center of the screen. That's why I try to center stuff on the ultrasound screen whenever I can. Not so much of a problem when I'm working with a nice big footprint convex array probe or curvilinear probe. However, when I change to the smaller footprint phased array P21, only 21 millimeters here, phased array, meaning that all the sound comes from one single point and it gets electronically steered into the body. Notice how these lines splay out quite a bit when I'm getting to the edges. Now, the advantage to having a small footprint phased array transducer is that I can see from the diaphragm superiorly all the way through Morrison's pouch to that lower pole inferiorly between the ribs. Using this larger footprint transducer, while I do have more elements in them and I've got beautiful resolution throughout these elements. The downside is that the footprint is so big that I might be putting it on 2 or even 3 ribs. In other words, I'll have these dropouts, these rib shadows down my screen, and that's why this probe is better used in the abdomen for the abdominal structures, like when looking at the aorta, looking at the gallbladder, the kidneys, the bladder, the pelvis, transabdominal of the uterus, that kind of stuff. Whereas this transducer is really designed to look between the ribs, looking at the heart and the lungs. And you can actually also see a really good view of the liver and the gallbladder as well when looking between the ribs. So, you got to really need both transducers in your armamentarium to get much better views of the abdomen using this probe. You wouldn't ever want to look at the heart with this probe. It's never designed to do that, though sometimes in a pinch you can get a subcostal view. This transducer really designed for the heart, though sometimes it is used in the abdomen. You can get away with it in the abdomen for really obvious structures like a late first trimester, second and third trimester of pregnancy. You can certainly get some basic information there with that. And as I mentioned, going between the ribs, you can see the liver and therefore the gallbladder with that probe. You can get away with it, but in the abdomen, you're going to get much prettier pictures anywhere subcostally using this C60 transducer. Now, what about the linear probe? The linear probe is what we sometimes refer to as an end-fire transducer. The sound beams are directed straight off the end of the probe. There's no array. In other words, it's not splaying out, so that you get the same lateral resolution moving across the field here with this linear transducer. This happens to be the L38, relatively long footprint here, linear, 38 millimeters across its surface here. They make all different types of linear transducers. Generally speaking, these tend to be higher frequency transducers that are used for the first few centimeters of soft tissue. Anything greater than 5 or 6 centimeters of tissue, you're going to need to switch to another transducer. So this is all the near field stuff. So think about soft tissue cellulitis versus abscess. Think about DVT work, vascular access, all the musculoskeletal functions such as, looking at fractures, reducing fractures, joint effusions, tendon ruptures, nerve blocks, those types of procedural guidance, things like that. This tends to get used quite a bit. Even appendicitis, you can use this transducer in kids and smaller individuals. This would be my go-to transducer for a lot of those bowel things in kids and small individuals, whereas larger patients, I'm thinking about that C60. Okay, what about the concept of temporal resolution? Temporal resolution means the frame rate, the number of frames per second. And so when you're working with the heart, you want a really high frame rate when you're because you want to see the range of motion of those sarcomeres as that heart is going between systole and diastole. So with the heart, you really want a high temporal resolution. But other times, you're willing to sacrifice some temporal resolution in order to get more artifacts scrubbed off the screen. And so a lot of abdominal software settings, you'll see at the expense of temporal resolution, you'll see less artifacts on the screen. And so because as the JPEGs are coming back to the ultrasound machine, the machine is doing its best to scrub off artifacts. And as it does that, it may need to slow down the frame rate. And so just sort of keep that in mind. So what else affects temporal resolution other than the software setting? Well, the depth. The more deep you go in this machine, the more it's waiting for those return echoes. So increasing the depth will decrease the temporal resolution. Somewhat, but the major thing that really dumps your temporal resolution is when you're working with color. Now, some machines will have a little, insignia here, a little tell you like the number of hertz or frame rate over here. Other machines do not, and it's sort of left up to you to tell. So whenever we're working with color flow Doppler, pulsed wave Doppler, power flow Doppler, in this case this is color flow Doppler here, what we're seeing here is a lower frame rate, and when the frame rate drops, the temporal resolution decreases, and the image can look a little bit herky-jerky. And it doesn't matter which type of transducer you're using; they all have, some decrease in temporal resolution whenever you activate any of the Doppler functions. So that brings me to my next point. If you're looking for a vessel somewhere in the arm, for instance, like we're doing here, you'd think that you would just plop on the color flow Doppler and then start looking around. But as you see, as you move the probe, as soon as the transducer is slid on the screen, you get all of this flash artifact here. So there's one problem. And the second problem is the temporal resolution is lower than if we didn't have the color on. And so that's why I try to just only use the color or the pulse wave Doppler after I've identified the structure on B mode, and then I anchor my hand. I literally put my hand on the patient with the probe so that I'm not moving it around, and then I activate the color, keeping in mind to be always, you want to think more parallel and be less perpendicular when evaluating for a possible structure that you're going to see on Doppler. And so that's the issue here, temporal resolution. Turning up the frame rate will give you better temporal resolution. So whenever you decrease the depth, turn off the color, and switch to cardiac software setting, you will have the highest possible temporal resolution. Now, what about the probe indicators? Boy, this can be a very confusing issue for some people, and other people this isn't confusing at all. And so it all depends on sort of your ability to have spatial resolution here. And again, if you struggle with this, it's some people need to understand everything they're doing before they do it. Other people kind of jump in and start doing it, and then the understanding happens later. I think that if this is confusing to you, the image planes that we're going to talk about here, why is it that when you move the probe one direction, the image has the following effect? Does it go more towards the head, more towards the feet? If this kind of stuff is confusing to you, as it was to me for about 3 months, then I think it's okay to kind of give up, let it go, like why it's happening, and just go for, okay, memorize, you got to put the indicator towards the patient's head, and you stick the probe here on the body, and then, okay, there's the kidney, there's the liver, good to go. Over time, it will dawn on you why it is you're getting the image that you're getting. And so just to sort of clarify here, every time you pick up a probe, look for the indicator. Sometimes it's a dot or a nipple, a little groove, a little notch, something like that. You're looking for the indicator on the screen. And the standard orientation in the sort of radiology abdominal software setting, which is the standard that we use in the United States, is to have the indicator towards the patient's head in a sagittal plane and towards the patient's right in a transverse plane. So this is a sagittal view here of the IVC as it's stretching out across the screen. This is towards the head, and this is towards the feet. And sagittal means basically longitudinal as you approach the body from the anterior approach. Now, this is also the IVC seen over here, but it's a transverse plane. The indicator's to the patient's right, so everything over here is to the patient's right. Over here, everything's to the patient's head. Now, what if I accidentally aim that indicator towards the patient's feet? Well, you may look at this and go, no big deal, it's just upside down, but there's the IVC, I see it moving there. But to me, that's like fingernails on a chalkboard, and I'm going to flip it back the other way. So this is to the head, and this is to the feet. Now, as we go through this, we can see here sagittal plane, indicator is towards the patient's head, and the skin line, I like to refer to that as the skin line, what's up here nearest the probe. This is to the head, and this is to the feet. As I go deeper or posterior into the body, I finally arrive at the inferior vena cava. It's located underneath the liver. And I can see this is blood draining towards the draining towards the right atrium of the heart is up this way, though off the screen, and the blood was coming from the lower portions of the body down here. So the blood is actually traveling in this direction towards the head. Okay, sagittal plane. It means longitudinal when approached from the anterior location. Okay, now transverse, indicator to the patient's right, as if we're standing below the patient's feet. Here's that same blood vessel, the IVC, and this is to the patient's right, this is to the patient's left. This is skin line anterior, and going deeper into the body, this is posterior. Okay, everybody's cool, no problem. This is where people get confused. Coronal. Coronal, like its sagittal cousin, you aim the indicator towards the patient's head, and I say it's the sagittal cousin because it's also a longitudinal plane of the body, But now, instead of, this is now the skin line being lateral, and as we go deeper into the body, the sound is going medially, and that's what confuses people right there. This is still towards the patient's head. This is still towards the patient's feet, just like a sagittal plane, but because we're coming from the side of the body, skin line is now laterally, and this is medially going in here. Okay, this is towards the spine, if you will. Okay, now what about the depth? Depth is the most common control that I adjust on the ultrasound machine. If I could only have one button on the machine, assuming the machine was already on, I would use the depth button. In fact, it'd be wonderful if we had a depth control right on the probes themselves, because then I could almost not really have to go to the machine that often. This is the most common button that I use. So this arrow pointing up means to go more shallower, and this arrow pointing down is to go more deeper, going back to that submarine reference earlier. And so shallower and deeper. What does that mean? You want to always maximize the screen real estate. This is the most common rookie move I see. People mistake this, and they forget all about the depth, and they get excited because they're finally seeing some structures on the screen they recognize. They see the kidney in Morrison's pouch. They see the diaphragm over here. They see a hepatic vein coming along here, and they're just geeking out on their image. And everything down here, though, however, is wasted screen real estate. So what do they got to do? They have to decrease this depth, or they need to go up. So they push that button, and now they go to 18, and it's much better. They're not wasting so much real estate down here. In fact, if you look at these hash marks over here, 1, 2, 3, 4, 5, every fifth hash mark we get kind of a bigger white dot. 10, 15, 16, 17, 18. Okay? This is 18 centimeters deep, still wasting some real estate. So I'm going to come over here and push that button one more time. And as I do so, now we're at 14. It makes those chunks of jumps. It jumps in this particular machine every 4 centimeters. But now we can see the diaphragm is down here. It's taking up, here's the kidney here, Morrison's pouch, the interface between the liver and the kidney. This is a coronal view, indicators towards the head. We have it on the resolution setting, so things look about as good as we're going to get them in terms of our depth and our resolution setting. We're pretty happy right now. So just keep that in mind. You want to maximize the screen real estate. Well, what about the gain? The gain is the strength of the returning echoes, and we could turn up the gain in the top half of the screen, the bottom half of the screen, or the entire screen at once. So right now, this image is kind of overgained at the top and undergained at the bottom. So to compensate for that, I could turn up the far field and then turn down the near field. And as I do, well, now I have the opposite problem. I went too far, right? The top half of the screen is undergained. The bottom half of the screen is now somewhat overgained. So what I'm going to do is I'm going to just turn down one of them. I'll choose the far gain, turn that down. And now the gain is definitely uniform from top to bottom. However, it's uniformly undergained. I mean, I can kind of make out the diaphragm here, and here's the kidney. And in a really dark room, like a jet black room with no lights on at all, yeah, I might be able to get away with this gain setting, but the reality is we work in rooms with light, and so we need to occasionally turn up that gain to compensate for the fact that the room usually has some lights on in it. And I actually had them install dimmers in all of my trauma resuscitation bays, and in every room I could get them to do it in after that, because it is so convenient to have a dimmer in the room so we don't make this mistake, which is overgaining the image. Now, the area between the kidney and the liver is kind of washed out. In fact, I can't really tell the difference in echo texture here between these two organs. And if a little sliver of black fluid in Morrison's pouch was sitting in here, I might miss it if this was overgained. So you can cause a false negative by overgaining the image. So what I'm going to do now is I'm just going to back off that overall gain until the gain gets perfect. Now I can see that the number one most echogenic structure on the screen is my diaphragm, followed by the pelvis or sinus of my kidney, followed by the liver architecture, followed by the renal cortex, and then the least echogenic thing on the screen is going to be this hepatic vein. And so you'll see questions like that come up on certain exams where they want you to rank everything out in terms of its echogenicity. And if you can tell the subtle difference that the liver is slightly more echogenic than the cortex of the kidney, because the liver is ever so slightly more dense than the cortex of the kidney, that's why it appears more echogenic. then you've got your gain settings correctly. Now, is there one more thing I can do to make this image perfect? I've got the resolution setting on. I could actually decrease this depth down to 14, and that would maximize my screen real estate. Artifacts. What about artifacts? This is sort of the last topic here. I'll tell you, artifacts, as opposed to other imaging modalities, with ultrasound, artifacts are helpful. In fact, a high attenuating artifact helps me because there's a shadow that persists underneath a high attenuating artifact. By the way, attenuation means the weakening of sound as it travels into and then out of the body. So sound's constantly getting attenuated or weakened. And some things really attenuate sound, like a dense structure, like a gallstone. Here we can see the gallbladders here. Here's a gallstone, and it's actually a round structure, but we don't see the rest of the gallstone because the sound is coming in and it's bouncing right back. Because this gallstone is so highly attenuating, we can't see the rest of the gallstone down here. So it looks like it's like a little, semi-circular thing here, but it's actually round. We just don't see the rest of it because it's being attenuated and a shadow is persisting. Now, a low attenuating artifact is what sound loves to travel to. So sound travels through the bladder, speeds up, and everything behind the bladder becomes hyperechoic. We could see that here. Here's the low attenuating effect of the bladder. Everything back here is overgained or hyperechoic back here. In fact, we could miss a wedge of free fluid unless we turn down the gain, which is why you want to turn down that far field gain whenever you're looking behind a low attenuating structure such as the gallbladder. We call that posterior acoustic enhancement. Whenever the sound travels through something that's low attenuating, everything behind it becomes hyperechoic or enhanced. Now, gas is the true enemy of ultrasound and scatters the sound beam in all different directions, and stuff you can't make any sense out of on ultrasound is probably scattered from gas. Bow gas in this case. Anytime there's air, it's going to scatter the sound, and you're going to basically lose your image. And the way you get around that is to just push really hard so that loop of bow compresses and no longer, or displaces that loop of bow out of the way, no longer scattering your sound beam. Refraction is another type of artifact. Sound's coming from one medium into another medium, and then it gets redirected. And on the edge of that structure, you're going to see a shadow coming down. So that edge artifact is sometimes referred to as refraction. And we see that on the edges of structures like the bladder or the gallbladder. We'll see a shadow coming down on the edge of, in this case, a blood vessel. We see the shadow coming down here. And it's sort of nice because these shadows outline the edges of the structure. I could see where that structure ends, actually. And so, but don't mistake refraction artifact at the neck of the gallbladder for a gallstone. It's just the sound that's going from medium 1 to medium 2 getting redirected, not unlike Snell's law, where a pencil's sitting in a glass of water. The light, sort of the bending of the light, this is the bending of the sound, and you get this edge artifact that occurs on each side of it. Another type of artifact you commonly encounter is a reverberation artifact. Reverberation artifact looks like equidistant arcs that come down from the top of the transducer, and we can see reverberation artifact here in this image here, these equidistant arcs that are coming down. Those aren't tissue structures, those are just reverberation artifacts. And we see it here with the gallbladder commonly. And no, this is not sludge in the fundus of this gallbladder. This is instead reverberation artifact. You see these artifacts cross that wall of the gallbladder here. And reverberation is seen throughout foreign objects as well, particularly metal and plastic foreign objects. You'll see equidistant arcs coming down. The sound's reverberating when it hits a metal or a plastic object, and you'll see those coming down there. Now, mirror image artifact is a weird one and takes people a while to understand. I get a lot of questions about this. Basically, think back to that coronal view of Morrison's pouch. Here it is over here, liver, kidney, and this is the diaphragm here. And something weird happens in the absence of fluid in the chest. So in normal individuals, we get this mirror image artifact. The sound goes through the liver, and when it encounters the diaphragm, instead of getting on the other side of the diaphragm in normal individuals, it rolls along the diaphragm and then eventually makes its way back to the ultrasound machine. And the ultrasound machine thinks to itself, that was weird. I sent that sound out there. It took it a while to come back to me. Therefore, there must be something further down the screen. In other words, something further deeper down the screen because it took longer for that sound to come back to the machine as it was sort of, going along the diaphragm here. It took a little longer to come back, so it mistakenly plots liver the stuff the sound was rolling through as it was going along here in the chest. So remember, coronal view, this is towards the head, this is towards the feet. Therefore, superior to the diaphragm is all chest. And so in normal individuals, it plots the liver up in the chest. This is what it looks like. This is the mirror image artifact. Now, why am I making such a big deal about this? The reason is because ultrasound is awesome at diagnosing fluid in the chest because of this mirror image artifact. So when you lose this mirror image artifact and you see black stuff up here, well, you've just diagnosed a pleural effusion, or in a trauma patient, potentially a hemothorax. And so that's why this is so powerful. And it rules it out with incredible test characteristics, much, much, much better than a chest x-ray could ever dream to do. And so that's why this is so important and something that confuses people, but you get used to it when you see it all the time. So to summarize here, you got to know your anatomy. You got to know what structures lie next to other structures. Ultrasound has, 3 orthogonal planes, if you will, like everything else. It's got the sagittal, transverse, and coronal planes, but you know what? You end up visualizing all of this anatomy in at least 2 of these planes. In fact, I would say ultrasound is infinity planes, because as you fan that transducer through these organs, in your mind's eye, you're recreating them. Kind of like when you push on the abdomen with your hands without ultrasound, like back in the day when you're doing the physical exam, you're thinking back into your mind's eye, I wonder what's underneath my hands right now. Well, with ultrasound, you're actually seeing what's underneath your probe hand. And as you fan through these 2-dimensional planes, you're reconstructing all of those anatomical structures in your mind, which is why it's so important to teach ultrasound while you're teaching anatomy to students. Now, you want to define the boundaries of any organ that you're looking at, get it all the way to the edge of the gallbladder, and then fan all the way back through it again, and realize where that organ stops and starts. You want to choose the proper transducer, whether it's the P21, the C60, the L38, or the intracavitary transducer. You want to know why you're choosing those. And I'll tell you, I go back and forth between these transducers quite a bit during one exam. You want to learn those acoustic windows, where to stick the probe on the skin in order to generate the image. You're going to spend the rest of your life learning how to do that, but it does become second nature over time. And then you want to learn how to maximize those system controls. The depth is the most common button I push, and certainly adjustments of the gain and occasionally the frequency. Now, people always ask me, what is the typical learning curve of ultrasound? Well, I can tell you that the first time I learned ultrasound, I remember I was in residency, and we had this old ultrasound machine handed down to me. This is like 1998, 1999. And my residency director, Dr. Mark Langdorf, was giving a lecture on ultrasound. And he was saying, okay, everybody, you see this? This is the gallbladder right here. And, there's obviously some posterior acoustic shadowing. And there's a little gallstone over here causing another shadow. And then here's the portal vein, and anterior to it is the common bile duct. And you can see here the common bile duct is actually dilated. And there's some pericholecystic fluid, and there's some anterior wall thickening. And this is an obvious case of cholecystitis. And I remember sitting in the room, and all I saw was this. I saw a snowstorm. And I said to my friend next to me, I said, did you understand what Dr. Langdorf was talking about in that ultrasound lecture today? And he said, man, all I saw was a snowstorm. And I said, yeah, same here. That's all I saw, a snowstorm. But you know what's happened over time is that the machines have gotten much better, and we've gotten much better. And so you reach that step 2 pretty quickly, where suddenly Morrison's pouch is jumping right out at you. And you're seeing the diaphragm, you're seeing the mirror image artifact, and you're seeing the other structures on the screen come to life. And that's a very empowering moment in this learning curve. And luckily, as the ultrasound machines have gotten much better in quality and taking advantage of Moore's law, the fact that the microprocessor speed doubles basically every 18 months or something like that, the ultrasound manufacturers have been able to process these images and scrub off their artifacts and make these high frame rate images come to life. And so that's why I think the learning curve has actually been sped up quite a bit as well, thanks to those manufacturers. But you know what happens, step 3, you start inventing ways to use the ultrasound machine. I call that the lonely or the brave stage, where you start sort of going beyond, your abilities with it. And, for example, I saw one time early on in my career, I walked into a trauma bay, and I saw one of my residents taking the endovaginal transducer and inserting in the mouth of an intubated trauma patient. I said, "What are you doing?" "Oh, I'm trying to basically do a transesophageal echo to see if there's an aortic tear." And I said, "Okay, that's not what we're trying to do here. You need a special other transducer, a transesophageal transducer, and a lot more training." And so, that lonely or the brave stage, you got to be careful you don't go beyond your limitations here. And because once you make a mistake with ultrasound, you kind of end up pulling the reins in and then you're safe again. I think it's better to completely avoid making those mistakes and stay within the parameters, within the guidelines, and within the objectives of what we're teaching. Now, one of the things I can tell you is that ultrasound is really the hard thing, actually, as you'll find, is actually getting the image on the screen, actually producing image, being the sonographer. And over time, this goes away, and you get better at it. But it is an art. It's not simply putting a patient on a table and pushing a button. You are obtaining these images yourself, and it's a whole profession in and of itself, because you're trying to decide on all those factors that we talked about. And then there's a whole nother factor here, which is how hard you need to push. It's sort of the Z factor, if you will. It's how hard you push into the skin in order to get the image on the screen. And that's something that you're going to need to learn over time. And you're going to need to practice patient after patient after patient. And you want to allow yourself the time to practice that. The time to practice that is not during a shift in the ICU or in the ER. The time to practice this is on your day off, and come in when you don't have any other responsibilities and just start putting probe to patient. You do that enough and you will become better at this, more confident, and more accurate.